Hey, welcome to Best Practice Health.tv. I'm really excited to see you. Did you miss us? We missed you. Thanksgiving was wonderful. It was so good to see the family and get out and eat and eat and eat and eat. And I think it's a good thing I didn't check my CRP level after this weekend because I'm thinking with all those delicious pies and desserts and meats and it's got to be through the roof. It's got to be terrible. And I'm guessing that you're a lot like me and that you maybe didn't have your cleanest eating week of the year. That's not what we were thankful for. And as a result, we can expect there's going to be some heightened levels of inflammation in our bodies. So it was never a better time to get back to the straight and narrow, to reduce our inflammatory content in our bodies, and kind of move on to Christmas where we can rip it all down again and have a great time. We really did miss you. On Friday, we normally do our live show. And in the live show, we take all the questions off the social channels for the week. I wanted to let you know today we're going to catch up. We had a lot of really excellent questions, and because we missed you on Friday for the vacation, we didn't want to leave you hanging. But I did want to let you know about a few different things. And the first one is very excited. We're working on a new format for submitting your live questions. That's a video format. And I know some people don't want to be on video, and I get that, but this would be anonymous. You can put your name or not, depending on how you feel. You can or cannot include your imaging. Of course, we can give you a way better answer if we have your imaging. And you can tell your story. And I just feel like it's going to be a super efficient way to get your information out there. We want to help you. We're here to answer your question. But the beauty of the internet is that a lot of other people have the same question. And I can tell you, I practiced medicine for 20 years, or 30 years if you count the training time. And a lot of people have the same questions. And there's no shame in that. It's everyone's different, but our bodies are built and structured around similar themes, and they break in predictable ways. And as a result, it's really helpful to repurpose one answer for another person. So somebody may ask, and I'll answer your question, even if they're not you. So it's really helpful to have it. The second thing I want to tell you is we're really working on those social channels. So we're called different things in different places. So on Facebook, we're Phoenix Spine and Joint, same on Instagram. Check it out. I think you'll see a lot of interesting content, a lot of interesting things happening, a lot of hopefully inspirational messages. You know, there are those of us who love the holidays, who thrive on the connection with family and the situation. And then there's a lot of other people who have the opposite experience. The holidays are actually a lonely time and actually a time of torment. There's a lot of possible reasons for that. If you've lost someone who's dear to you, who you loved around the holidays, it's almost impossible to disentangle that loss from your feelings toward the holiday. It takes time. If it is possible, it's certainly something that takes time. But it's important to remember while some people are celebrating the holidays, other people are dreading them. And if you're dreading the holidays or if you're celebrating the holidays, this is the right place for you. We want to be here with you and for you and talk about things that you can do, healthy hacks that you can do to make your life better. Let's talk questions. Let's get down to it. Got some really interesting stuff this week. I'm really excited to share with you. First one comes from M. Chevalier Sewell. I was told it wouldn't heal due to osteoporosis. A little bit of context. This is on the Is There a Cure for Spinal Stenosis Without Surgery video, the Clinic episode 1. So this was in our show, The Clinic, where I sat down with a patient and went over spinal stenosis and everything about it. And Mr. Chevalier Sewell says, hey, I was told I couldn't get my spinal stenosis fixed because I have osteoporosis. And whoever told you that was totally wrong. I'm so glad you came on the show because that's completely wrong message that's fake news, buddy. That's the wrong story for this plot. Let me show you why. This is our Shorty spine. Hi, Shorty. And in the spine, remember, there's the little bumps you feel along somebody's back. And then there's this horizontal bone here called the lamina. And the lamina is the roof of the spinal canal. The lamina is the roof of the spinal canal. When you relieve spinal stenosis by doing laminectomy surgery, you raise the roof, but you don't raise it, you actually reconstruct it, you remove it. Osteoporosis is a condition of the failure or difficulty of our skeletal system to replenish itself. It has to do with how we rebuild our bones. By the way, I found a really great page from the NIH on osteoporosis, www.bones.nih.gov. Check this out. You know, the National Institutes of Health, where I used to work, is almost always the best and most complete source of information about something, and that's a really good one on osteoporosis. Long story short, osteoporosis is about replenishing bone. In laminectomy surgery, the surgeon under a microscope through a tube drills out the bone, sucks out the bone dust, and sends it to the garbage. What difference does it make how well your bone grows back? It's in the garbage, right? There's no, those two things don't go together. Osteoporosis has nothing to do with laminectomy. So no, having osteoporosis is not a contraindication or a risk factor for having laminectomy surgery. Now, they might have been talking about fusion surgery and putting anchors into bone where the bone is soft and isn't going to heal properly, or wanting the bone to heal across a joint. Yeah, osteoporosis can be a risk factor for fusion, but not for laminectomy. So let that go. Please get your spinal stenosis fixed, people. Spinal stenosis is a progressive disease. If you have it, it's only a matter of it getting worse. The most common question I get with spinal stenosis is, how do I know when it's time for surgery? It's time for surgery whenever, as soon as you can't live your life or control the symptoms with low-level non-weight-bearing activity. So walking in water, motion is lotion, really lubricates the spine and helps with spinal stenosis. You might be able to modify, if you get spinal stenosis after walking 1.5 miles, you can walk 1.25 miles and you're just fine. All those, you don't need to have surgery. But once you get to the point where I can't walk 1.5 miles, I need to walk that to get to work or to be with my grandchildren or to enjoy my vacation. I can't do the things I normally want to do because of spinal stenosis. It's time for surgery. It's like I like to say, you'll never be younger or prettier than you are right now. Never. We always think, oh, I'll get it fixed later. You know, one of the saddest ones is always ladies who are taking care of an elderly man. He passes away, but by the time he's gone, their heart condition has progressed, their age has progressed to the point that they're not safe to have the surgery, and then we're screwed. Once you're medically unfit for surgery, there's just nothing. The only thing that works is surgery, so when you can't have surgery, you are screwed. And now the rest of your life is progressive loss of mobility, loss of bladder control, loss of bowel control, sexual dysfunction, everything. Just there's a window where you can get this fixed. Don't miss your window. You'll never be younger or prettier than you are today. Second question from Gary Clark. My son is on antidepressants. The doctor literally said that his depression was caused by a chemical imbalance. That was the consensus with most doctors I have talked to. Your point about that not necessarily being the case is good and valid. That's a really interesting point. First of all, Gary Clark, thank you for engaging in this forum. I too have a family member who has experienced very significant life-threatening mental illness. I know what that's like, and my heart goes out to you, brother, for dealing with this with your own son. In my case, it was my sister, and thank God many years ago. It hasn't been a problem lately, but I know how helpless, I know how intense, and I know how angry these issues make family members. So I applaud you for taking such a proactive and informed approach to helping your son. Because quite frankly, in our system today, you're probably the only person, you're in a good position to help. He needs you, and good for you. You never stop being a dad, do you? Well, second thing about the doctors disagreeing, yeah. As medical doctors, we have to present things in terms that people can understand and communicate because we want them to do what we think are the right actions. And that may be take a medication, that may be stop a medication, that may be lose weight, that may be stop smoking. Whatever it is, we're trying to get you to do, we have to communicate with you. That's different though, right? Than neuroscientists who may be studying a disease from the pathophysiology of the disease. They have no dog in that hunt. They don't care. They're not trying to persuade anybody. They're trying to understand the capital T truth of the situation. And so there do come times where the way things are explained is sometimes not really the best representation of the science of the moment. And I believe that one of these things is definitely the neurotransmitter story on depression. The people who I respect will tell you, quite frankly, we don't really know. We use science as a tool in areas that we don't know that have a big impact on human beings. Science is our tool to help help clarify and understand things so that we can then lead to better treatments. But it's definitely a case where we don't know. So thank you for your patience because we don't know. The problem I see with this new evidence is that the meds aren't a cure. They're just making what's really going on. They're just masking what is really going on. With no clear rationale for what causes depression, aren't we just constantly changing a bandage on a wound that will never heal? Yes. Yes. Yes, yes, and again, yes. And that's a lot of medicine, right? That's not just mental health. How about Aleve or ibuprofen, NSAIDs? If I injure my elbow and I have a cartilage defect that's causing inflammation in the joint and I take it, am I changing what's going on in my elbow? Well, no. I mean, that drug is circulating to my entire body. It's not specific to the problem. It's just reducing the inflammation to cover it up. In fact, a lot of drugs, that's exactly what they are. There are some drugs that are better, and no one would argue. For example, Prilosec or Pepcid or omeprazole or famotidine, whatever we used to call it, Tagamet or whatever it is. Those drugs are very specific to the pathway that makes acid in your stomach. They're called the H2 blockers. And because that pathway is unique to your stomach, those are Ganga phenomenal drugs. They're clean drugs, very few side effects, very wonderful. There's no clean neuropsychiatric drug. All of the major drugs, Haldol, Thorazine, phenobarbital, they're all tranquilizers. They don't fix anything. They just cover up. Why? Because we don't have anything better. Someday we will. Someday we will. And it may not be a drug, but it probably will. It'd probably be a drug that allows us to target certain populations or modulate neuronal synapse signaling or do something in some way that will improve things. But absent a better drug, we use what we have in terms of drugs. And then also, I think that's why the best people in this area recommend combination treatment. You want to do your cognitive behavioral therapy for depression, but sometimes it's not working and you just need a little oomph to get you over the hill, and that's pharmaceutical management sometimes. Sometimes you try that pharmaceutical management and you're a zombie. Guess what? It didn't work for you. Stop it. You got to rely more on the therapy. So everyone is different. Every situation is different. It's a doctor's job to win the game for you. It's a doctor's job to help quarterback your care in a way that they get relief from the symptoms of the disease. And in the case of depression, that's depression. Aptly named disease, right? So I agree with you, but I don't think that's a reason not to use antidepressants, although it's a hell of a good reason once we have something better. And I'm looking forward to that day. I'm sure not as much as you. Again, I want to express my extreme admiration for you and what you're doing for your son. Shanti Peters says, I've been having low back pain for 4 months now, every day. I had to stop exercising. I'm doing all kinds of stretches every day, but nothing is really working. MRI now, I guess. I don't have any pain down my leg. Thank you for that clue, Shanti. Shanti, thank you for that clue. So, I mean, there's so many causes of back pain, right? Not really. You can kind of lump them into three big ones. One is nerve root pain, or nerve roots pain, can be more than one root. That's pain that's primarily down the leg. That's not Shanti. That's not Shanti, because Shanti doesn't have leg pain. Could be, right? Could be an unusual presentation, but probably not. Second, so there's two other things that are the vast majority. One is discogenic low back pain. This is, in Shorty here, this is a disc. And if the disc tears, that hurts, and that's discogenic low pain. That's about 4% of all low back pain. So it could be that feels like a knife in the back. It's a very specific, it's usually along the middle. It's not usually activity related. Sitting actually makes it worse. So it's rare, but it's real. And then if we turn Shorty around, we've got these joints along the back. This is the facet joint. The facet joint, here's bum going up to the head, facet joint. And the facet joint is a very common cause of pain, about 40% of all low back pain. So look, we can narrow it down to it's most likely either a torn disc or a facet for Shanti. There's 10 times greater probability off the bat that it's a facet. So Shanti, you probably got facet pain. Let me show you what that looks like. I think it's actually pretty helpful to get a better sense of it. Check this out. Let me get this guy over here so you can see, and then we're gonna zoom in. All right, so first of all, let's start with Shorty. So here's the bumps you feel along someone's back. And if you slide down that spinous process, you get to the facet joint. Now, let's go over to this diagram. This is the spinous process, the bump you feel along someone's back. And if you slide down the lamina, you get to the facet joint. And this is not a normal facet joint, ladies and gentlemen. This thing is terrible. Let's bring it up here and look at it. So there's swelling and erythema there's blood into the bone. The cartilage is all jacked up instead of being smooth and bends easily. One level glides over the other. Ain't no gliding going on here, people. This is abnormal arthritic facet joint. Now, this has its own characteristic feeling. Remember when the torn disc, I said it was like a knife in the back? This facet pain is a little different than that. It's off to the left or the right. It's worse with movement. It feels like it's in your hip for reasons that we don't really understand, but it shoots down your butt, feels like it's in your hip, and then sometimes even burns on your outer thigh and sometimes not. So Shanti, the odds are that that's the kind of pain that you have. And the treatment for that pain when it's that severe after several months is, yeah, you need an MRI, but it's probably not going to contribute very much. What you really needed was an X-ray. The X-ray is going to show arthritis most likely if this is your issue, which it probably is. Then you go into a pain management doctor and they do a medial branch block. A medial branch block is an injection. So see, one thing that's not shown, you know what's wrong with this, this picture is it doesn't show you the most important nerve, which is, so just for reference, here's that spinous process, slide down into the facet joint. This facet joint is red because we're showing it as the injury. Now, see these yellow things? These are nerves. And this is a nerve that comes into this facet joint. This is a nerve that comes into this facet joint, and this is a probe. But let's pretend this was a needle. If they put a needle in here and injected some numbing medicine, right, just a tiny drop, like not an infiltration, just a tiny, tiny, tiny drop, right on that nerve and on nothing else. So if they knocked out that nerve and you had your pain coming from a facet joint, how would you feel? You'd feel great, right? You'd have no pain. That's the good news. The bad news is as soon as that numbing wore off, the pain would come right back. This is the equivalent of going to the dentist with a cavity, your tooth hurts like heck. The dentist numbs you up and then says, oh, sorry, I got a golf tee time, I gotta go. Dentist leaves, and then when that numbing wears off, is the pain gonna come right back? Yes, sir, it is. Or in your case, Shanti, yes, ma'am, it is. Because they didn't do anything. Same thing here. So if they did this medial branch block, by the way, this nerve right here is called the medial branch. It's the medial branch of the dorsal branch of the spinal nerve root. So they did the medial branch block. If you got a few hours of relief and then the pain went away 100%, then came back 100%, bam. It's from the joint, right? They didn't numb up your disc. They didn't numb up your nerve root. They didn't numb up anything. They numbed up just these pain fibers going into that joint. And then they can do actually what's depicted in this. They can do what's called radiofrequency ablation. They go in with this probe. They turn on the radio frequency here, and it buzzes those pain fibers. And that disables them for some period of time. It's not a permanent fix. It's just not. We wish it was. Don't get me wrong. We wish you could put a needle in there blindly and buzz it and it was a permanent fix, but it's not. It just isn't. So how well does it work? Well, there's been a number of studies, and I think the way I put them all together to help you get a sense of it is the 60% of patients get 80% relief for an average of 10 months, 60, 80, 10. 60% of patients get 80% relief. So if your pain was a 10 out of 10, now it's a 2 out of 10. That's 80% relief. 60% of people get 80% relief for an average of 10 months. Does it come back? Yeah. But on average, how'd you like 10 months? That would get you from, if you had it on Christmas Eve, that would get you through the following Halloween, right? That's pretty darn good. So yeah, okay, close, right? I'm 1 week off, but close. So that's pretty darn good, and that's worth trying. Now there is an endoscopic version of this procedure where instead of this guy, this probe that buzzes, we put in an endoscope, and you can see this little pain fiber, and you cut it, and then it can never come back. That's called direct visualized rhizotomy or dorsal radiofrequency ablation, endoscopic radiofrequency ablation. So it's done under direct vision, and you don't buzz it, you cut it, so it never comes back. And that's a permanent procedure, but it requires a specialized operating room, a specialized surgeon. It's not widely available, and it's not covered by insurance. It's like they say, other than that, Mrs. Lincoln, how was the play, right? It's not covered by insurance. It's not widely available. It requires a specialized surgeon, and it's hard to get. But if you can get it, it's phenomenal. I really, really like it. Really, really a great procedure. Okay, anyway, long answer to a short question, but that's the answer. Now let's get this back. All right, this came from LM. So the treatment for a herniated disc is basically pain management. Can it be pushed back into place? Aren't there non-invasive ways to push it back in place? Great question. I think the best way to answer that is to look at this video, which I'm going to show you over here. Okay, so here's the video I like to do that shows you how disc works. So this is the nerve root, the yellow. This is the annulus of the disc, and this is the soft part, the nucleus. So when the annulus strains and loses integrity and bulges out, this is what they call a bulging disc. And then the annulus rips. That's an annular tear, and that can become painful in and of itself. But then the nucleus, it's soft, right? Nothing's holding it in there, so it comes right out. and it bangs up against that nerve root. The nerve root doesn't like to be banged, but even more, it doesn't like to touch the nucleus. And so the nerve root becomes inflamed, and that creates nerve root pain, which shoots down your leg. That's a condition which you'll often hear called sciatica. That's what sciatica is. When you hear that word sciatica, put this in your mind. Okay, so now the question is, well, can't you just shove it back in? Well, first of all, this is deep inside your body. So all that's happening, that view is right there. There's no way to shove that back in there except surgically. And there is a surgery where we access that place, and that's called microdiscectomy surgery. But what you're saying is, well, why can't you just push this back in? Well, because it would come right back out again, right? The annulus is still torn. All right, why don't you just push it back in and then sew it up? Well, because it has very limited healing ability. Takes it about 6 weeks to heal, kind of, that because it has such a poor blood supply. That's why we got in this mess in the first place. So you can't just shove it back in because there's no way to fix it there. If you can't fix it there, you can't control it. So the answer to the question is no, you cannot do it. There's no way to just shove it back in. Now, so you say, well, okay, well, what do you do during surgery? In surgery, we go in and we cut this off. We take out any part here that's loose to try to get rid of, try to have less of it that can herniate out. And then we put the edges right up against each other with no annulus in between so that they will heal the best that they can. We enhance the chances of healing. And those activities are called microdiscectomy surgery. Microdiscectomy surgery. And it's a really good surgery if you have to have it. The thing about microdiscectomy is studies have shown that if you look at people 2 years out, if you randomize, flip a coin, you, surgery, you, no surgery. And then we look at how these two did. 2 years later, they're the same. So everyone says, oh, well, the surgery didn't do anything. Wrong. The people who had the surgery were better right away. They got better immediately right after the surgery. The other people went on and on and on and on and on with their pain. So how do we use that information? Pretty easily, right? If you can't bear it or it's causing neurological problems like functional numbness or weakness, and that means where you're having trouble, you have a foot drop or you can't use your leg or your appendage normally, or it's so numb you can barely feel it to walk properly, then yeah, you get microdiscectomy surgery. But if it's not that bad, it just bugs me, but it's not that bad, then wait it out because you're going to end up being the same either way. There's no point in having a surgery that's not necessary. And if you're going to end up okay healing anyway, and you have the time and the ability to do it. I have a lot of patients who are just like, hey, I need surgery. And I'll be like, hey, if you waited, it's going to be okay. And they say, no, you don't understand. I can't wait. I'm going crazy. And that's absolutely legit. Severe pain is a warning to take immediate action. That's how our bodies are labeled. That's how our bodies are constructed. So my hand's in the fire, my hand's in the fire, my hand's in the fire. And here's the doctor saying, yeah, your hand's in the fire. Is that okay? No, it's not okay. Like, I want to take my hand out of the fire. So it's understandable and it makes sense, but it's individualized. So the best way is to find a doctor who you trust, a good doctor, so you can take it from there. But is there a way we can just shove it back in? No. I wish there was. That would be super cool. DXR SAMUK 3IL. 3II. I'm not sure what you're after here. Dark Samurai. Is that right? I don't know what the 3 is, but I don't know. Dark something kill? I don't know. Anyway, I'm probably too old for this, but all right. Hi, I was in the military, got out on medical discharge in 2019. Thank you for your service. I don't know what your name is, but I really appreciate you fighting to keep us all free. At the age of 23, because I have spinal stenosis, disc degenerative disease, bone spurs, and a herniated disc. Keep in mind that we often use the term spinal stenosis like we're talking about the degenerative condition that happens with age, because that's usually what it is. But stenosis doesn't mean that. Stenosis just means narrowing. So if you have a giant disc herniation, and here's Shorty, and you can see the disc makes up the floor of the spinal canal. If your floor comes up so much that you're stuck up against the roof, that's stenosis. The walls of the spinal canal are the facet joints. If your walls come in so that you're being crushed like Luke and Leia in Star Wars in the trash compactor, you're being crushed, that's spinal stenosis. If your roof, which is the lamina with the ligamentum flavum on it, thickens so that it's pushing down on you, and then your floor is coming up, so you're being mushed in there, that's spinal stenosis. They're all spinal stenosis. So don't think of spinal stenosis as old people. Think of it as narrowing. But in this case here, we're talking to a guy who's 23, and he's got all of this stuff. He's got degenerative disc disease. He's got a herniated disc. It's hard living with these conditions because I wish I could live a normal life, but I just keep pushing every day. Next option I'm thinking about is surgery. Should I go that route? Maybe. It depends on what you want to exhaust all of the lesser risk options that are known to be effective first. So for example, if your underlying problem is back pain and that's coming from your facet joints, you want to explore having radiofrequency ablation after a test medial branch block with a pain management doctor. Why? Because it's a lot less risk than laminectomy surgery for stenosis. If your pain is mostly nerve root pain and there's a specific nerve that's impinged upon, then the opposite. You don't want to have radiofrequency ablation. You want to go see a surgeon and get that nerve root decompressed. So in a case like this where there's more than one thing going on, you really have to look at, your doctor has to look at your imaging and look at you and help you understand, okay, here's what I see on the imaging and here's what's coming out of your mouth and here's what I found on your examination. And when I compare all those things, your physical, your history, and your imaging, this is what I think is causing your problem. And this is how we can best, most safely, with the least invasive means possible, address it. So that's what you want to do. That's what you want to do. By the way, we can do that on this show. If you want to go over that, get on the show. Come on in. I'll do an interview with you. You can tell me what's going on. I can look at your images. We can pull them up. You can send them through the internet these days in a safe, secure portal. And I'd love to take a look, and especially anyone, especially one of our servicemen, anyone who subscribes to the channel, that is. PJE says, what would cause a knee to catch on the medial posterior knee when performing flexion and extension? Okay, so here's the knee. Hello, this is from the front. I'm in the back. And now we're horizontal and we're flexing and extending, flexing and extending. What would catch? Well, one thing you notice when you move the knee, most of the movement happens between the leg bone and the meniscus, right? That's the meniscus right there. If I pull this out of the way and crack it open so you can see it, we've got the leg bone and the meniscus, one here and one here. And this is lateral, here's the tibia. So here's the fibula. So here's the medial posterior, so it's right here. Looks like meniscus to me, but hard to say without examining you, but that's certainly where the meniscus is. It only happens when the knee is beyond 90 degrees, so about 30 to 45. Mechanism of injury was using a seated hamstring curl machine with not very much weight, but enough that I think I strained the hamstring tendon. Unlikely that you're doing a hamstring curl with low weight, unlikely that you would physically injure your knee doing that, right? More likely you had some kind of an injury that movement brought it out, but we'll never know. We'll never know. When I get the catching sensation, I usually put pressure on the hamstring tendon and it releases. Kind of feels like the posterior medial tibia is catching on the tendon as it rotates. There's some tenderness, but no sharp pain. I mean, it's always possible that this is some kind of elaborate tendinopathy, but much more likely in my mind is that you have a meniscal tear. And if you have a tear in the meniscus, the best way to find that out is to do a MRI of the knee. If this is bothering you a lot, then I would definitely do it. The prior to an MRI, as the video showed, is your knee pain coming from an ACL tear or meniscus injury, would be to do McMurray's test. Lay on your back, have someone bend your knee, rotate your ankle inward, and then straighten your knee. Rotate your ankle outward and then straighten your knee. If it catches or reproduces that catching motion when you're doing that test, there's a higher probability that it's the meniscus. And then you should definitely get an MRI to confirm it if this is painful for you. Because the reason to confirm it would be that you could be a candidate for meniscectomy, where the sports medicine orthopedic surgeon would go in there and shave out that thing and eliminate that movement. There's no other there's no tendon transfer operation or anything like that. So the other way to look at this is, if it's not your meniscus, it probably doesn't matter. There's no orthopedic surgeon's going to operate on you as far as I know. So that's that. All right, Amir Hussein says, after a long time, I start running with high speed. Suddenly my knee pains start, and it has been 10 days, and I have pain and little burning sensation. Can someone tell me what can be the problem? Should I go to an orthopedic doctor or rheumatology? I have no swelling in the knee or redness, just pain, and my knee sounds tick, 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 and I no pain during bending or flexing. I have pain when I walk. So you've got mild to moderate pain with walking in your knee 10 days after an injury. Please watch my video. You watched, is your knee coming from an ACL or meniscus, but I have another video on the initial care of knee pain. Please look on the channel on our knee pain playlist. It goes through the care of your knee pain at different stages. And you'll find really what you should be doing is rest, ice, compression. That's a neoprene sleeve, and elevation. For the first 3 weeks, you can care for yourself at home as long as you have no red flags, and it'll go through with you what those red flags are. Anti-inflammatory medications are really helpful during this phase if it's safe for you to take them. If you get to 3 weeks and you're still having pain, then it's time to see a doctor, usually a primary care doctor, to get an x-ray. If the x-ray is normal, you can do physical therapy for 3 weeks, 2 to 3 visits a week for 3 weeks. If that doesn't work, then you should be looking at an MRI and seeing a sports medicine orthopedic surgeon. Never see a rheumatologist for knee pain unless you have an inflammatory condition like rheumatoid arthritis or some other inflammation thing. Rheumatologists are like the primary care doctors of inflammatory joint disorders. They're specialists for inflammatory joint disorders. They're not primary care for knee pain. That's not them. Hi, Doc. Hi, Giancarlo Fernandini. Nice to meet you. I'm having low back pain. I'm sorry to hear that, Giancarlo. That stinks. Such a Grinch, right? Especially with Christmas. This low back pain is like the Grinch that stole Christmas. It's possible a herniated disc. My back is cracking a lot, like every 5 to 10 minutes. I need to crack my back to feel good. Important clue. For example, when I sit in the chair and straighten my back, it cracks and then it feels better. Also, when I move my body from side to side, it also cracks. Would this be a normal thing? I'm a little bit worried. No, it's not normal. Well, first of all, you're having back pain and you're having to kind of do your own chiropractic manipulation to relieve it. What cracks? It's not this, right? Your disc doesn't crack. What cracks are joints. So by definition, close, Giancarlo, you have facet-mediated low back pain, and it's a bummer. But the treatment is what we discussed earlier. It's to how long have you had it? It doesn't say in this, but after the basic algorithm is treat it at home for 3 weeks. If that's not successful, get an x-ray, then do physical therapy or chiropractic for 3 weeks. If that's not successful, you're now 6 weeks out, then you need to think about getting an MRI. If the MRI shows swelling of the facet joint, which it almost certainly will in your case, then you see a pain management doctor. The pain management doctor is going to do the medial branch block. If that's positive, you're a candidate for radiofrequency ablation. And if that's successful, you'll have no pain for Christmas. Grinch not going to steal your Christmas, Giancarlo. You're going to be okay until next Halloween when it's all going to come back. And then you do it again. Rinse and repeat. And unfortunately, that's kind of the best we have to offer right now for that problem. Whoa, I can't, God, this day is going so fast. We're up to our last question, and it's from Bara Flynn. What if I'm allergic to NSAIDs? Any other options with a herniated disc? This is on our short for herniated disc relief, low back pain relief. First of all, it's weird to be allergic to NSAIDs because they're naturally occurring compounds. Your body makes them, so are you allergic to the ones you make? It's more likely that it's a carrier or some other chemical that's in the pill. Most of the time when people have trouble with NSAIDs, I recommend they try Tylenol. Tylenol is different than the other than NSAIDs. It's processed, it's metabolized by your body in a different way. But it's something you should discuss with your doctor if you have a primary care physician. Steroids, non-steroidal anti-inflammatory drugs are anti-inflammatory, but steroidal anti-inflammatory drugs, steroids, are even stronger anti-inflammatories. So sometimes a pulse of steroids. They're just so dirty. So it's hard for me to recommend them because they're just so dirty. They have so many crazy side effects that, it's, so I guess I shouldn't have even told you. But I gotta be honest, you gotta know, but I don't know, steroids, they cause this euphoria. So everyone's like, oh, I could do this forever. No, you can't. Your body will your bones will get thin. You'll have all kinds of horrific problems. So anyway, that's something to think about. All right, people, that's it. That's it for today. I'm really psyched to have been with you. Thanksgiving's behind us. We have Christmas to look forward to. We're on a roll. We did the Halloween, Thanksgiving. Everybody on my block starting to put out their Christmas lights. So really fun time. I wish you the best. I look forward to seeing you this Friday. We'll go over more questions. Get ready for the rollout of that video question service. I'm really excited to get to answer your questions one-on-one through video. I think that'd be unbelievably cool. And don't forget to check out our social for bestpracticehealth.tv. I'm Dr. Dan Lieberman. Talk to you soon. If you have a question you would like answered on Best Practice Live, click the link to our website and complete the submission form. The more information you can give us, the better we can answer your question. So please contact us and we can walk you through uploading your imaging to a secure server. Please like and subscribe to our channel to stay up to date with information about your spine and joint health. Lastly, be sure to check out new episodes at 10 a.m. Pacific, 1 p.m. Eastern, where we answer all your questions.